Hello, everybody. Here's my disclosures, and we will start first with some switching strategy in a patient in virologic suppression. There are some reasons to switch treatment in virologic suppression, like simplify regimens because of high pill number, tolerability issues, comorbidity, drug and food interactions, and for example pregnancy as well. And what very important that I need to consider if a switching treatment in virologic suppression, to look for the whole history of previous ART, for the previous resistant issues, for adherence of patient, for of course for new drug and drug food interaction, and for some comorbid conditions. Here are some principles for switching strategy in virologic suppressed person that's recommended by EACS. That first will look for complete antiretroviral treatment history with HIV viral load, tolerability issues, genotypic resistance. We're looking for the future for remaining treatment options in the case this treatment will be not successful. We're looking for the possibility of new drug interactions with antiretrovirals and some other medication. And important to the patient should be seen pretty soon after switch treatment after approximately 4 weeks to check virologic suppression and possible toxicity. Here are some class pairing strategies recommended by EACS, like dual treatment with, for example, Dolutegravir plus Rilpivirine, free TC plus boosted darunavir or boosted atazanavir, and Dolutegravir plus free TC. The monotherapy with darunavir are very exceptional option only for some very difficult cases as not candidates for dual therapy regimens or for some other treatment regimens. Some strategies are not recommended by EACS. It's like monotherapy with atazanavir or Dolutegravir, triple NRTI combination, some specific two-drug combination, and of course treatment interruptions. It's not recommended more as a strategy for the patients. So we start with our patient case. A 71-year-old man is currently receiving Rilpivirine and boosted darunavir. The HIV first diagnosed in 1999 with HIV viral load 45 copies per mil and nadir CD4 cell counts 145. He started his treatment immediately after the first diagnosis with multiple antiretroviral treatment regimens and consistently undetectable since many years, and a stable treatment since 2012, and just a history of arterial hypertension since 2000, taking Rilpivirine and smokes 10 cigarettes per day. One day, patients admitted to neurological department with acute neurological symptoms and diagnosed and treated ischemic attack, TIA, and anterior ischemic optic neuropathy. And after discharge from the hospital, he get some new co-medication, but no HIV infectious disease specialist was involved in this decision. So get Clopidogrel, Atorvastatin, and Rilpivirine. So if we look for DDIs for drug interaction with Rilpivirine, it's not a problem at all. You see the Liverpool charts show us no interaction expected between boosted darunavir plus Rilpivirine and Dolutegravir plus Rilpivirine. If we look for DDIs with Atorvastatin, is more complex. Here you see that darunavir plus Atorvastatin at its dark yellow in Liverpool. That means it's possible to combine, but it will be very careful with the dosage of Atorvastatin. We only will start with 10 milligram once daily because of the increasing of Cmin and Cmax of Atorvastatin with boosted PRs. If you look for alternative, we could see that, for example, fluvastatin is light yellow. So it's possible to combine Atorvastatin as well. If we look for DDIs with Clopidogrel, it's even more complex. Clopidogrel is contraindicated and should not be co-administered with darunavir, boosted darunavir, because of decreasing of plasma concentration of Clopidogrel. It means we could not combine these two medications. They're looking for alternatives, and I see the aspirin is okay, it's green. So we decided to switch co-medication instead of switching antiretroviral treatment. So we switch atorvastatin to fluvastatin and switching clopidogrel to aspirin. After a few weeks, patient developed a severe intolerance of aspirin, have a stomach pain, nausea, and some hematomas on the lower arm. And our decision, we need some anticoagulants, so we decided to switch for directly acting oral anticoagulants like Rivoraxaban, but it's a question if we really stay in the same antiretroviral treatment. If you look for drug-drug interactions between anticoagulants and ART, we see, for example, for Rivoraxaban, it's for PIs, it's completely red. It means it could not be co-administrated together. For some NRTIs, like new one, like Dolutegravir, Rilpivirine is green. For integrase inhibitor, for not boosted integrase inhibitor, is no problem at all, and the same for NRTIs. So we go back to the EACS guidelines and looking again for completely antiretroviral treatment history of the patient, for remaining treatment options in case of virological failure, and we're looking, of course, for new drug-drug interactions. So here's some idea about our decision for switching ART treatment. So if you look for NRTIs, for example, it's okay together with Clopidogrel, with Rivoraxaban, excuse me, but the problem is a patient had multiple pre-treatment with NRTIs and have a story of lipodystrophy and intolerance, so it will be difficult to recycling this medication class again. So if you look for NRTI, it's no problem with Dolutegravir and Rilpivirine. For PIs, we look already, it's not possible because of co-administration. It's not recommended. And for integrase inhibitors, for non-boosted integrase inhibitor, for Dolutegravir and Bictegravir, it's no problem at all. So we decided to switch to a combination of Dolutegravir plus Rilpivirine. And the reason was we're switching in virologic suppression. We have no NNRTI mutations in the history, no integrase inhibitor pretreatment, and we are not expecting any drug-drug interaction with statins or directly acting oral anticoagulants. After 4 and 12 weeks of treatment, patient is still undetectable. Treatment is safe and well tolerated, but patients still have permanent slightly stomach pain, becoming acid reflux, nausea, and we perform gastroscopy, and diagnosis is reflux disease and esophagitis, and a patient needs PPIs. So we have the next problem here because of PPIs are not indicated or contraindicated even together with Rilpivirine, because of the significant decrease of Rilpivirine plasma concentration. You see there, all this combination, it doesn't matter which PPI will take, should not be co-administered with Dolutegravir, Rilpivirine, especially with Rilpivirine. So we have the problem with ART again. And we look for our decision, we try to find new combination for this patient. We're looking again for NRTIs, and this season NRTIs are okay because of drug-drug interactions, but patients have lipodystrophy and intolerance. but we're looking for treated C, for example. It's much less toxic. It not caused obviously lipodystrophy, and patient have no history of resistance for treated C, so it could be an option. The Rilpivirine could not be co-administrated with PPIs. PI, we have a problem with Rivoraxaban, and for integrase inhibitors still have Dolutegravir is okay. So we decided to switch this patient to Dolutegravir, treated C. We have no expected DDIs with Rivoraxaban, with statins, and with PPIs. We have undetectable PCR after 4 and 12 weeks, and treatment will be well tolerated and safe. Thank you very much for your attention.